Good evening, all the aspirants present here. It's the first session of our Brain Death and Organ Donation (CCS) session, and the speaker that we have here is Dr. Shraddha Patharkar. She is an associate consultant at ABMH Pune. Thank you, ma'am. You can continue.
Yeah, sorry for the delay. And per se, this is not just the organ donation topic. Uh, the cases will go through different vignettes, and then finally, I'll be talking about organ donation. So, am I audible?
Yes, ma'am, you are
Yeah,
audible.
okay.
All the
Yeah,
aspirants, it's going to be an interactive session, so you can unmute your mic, or if you have any doubts or anything, you can also share it in the chat box. Thank you, ma'am.
yeah. So, we'll start with the case. 30-year-old male, alleged history of road traffic accident. Motorcycle collided with the speedy four-wheeler coming from the opposite side. He became unconscious at the site of injury. On arrival of trauma response team, his GCS was E2M4VT, that is 8 by 15, heart rate of 130 per minute, BP was 180 by 100, saturation 92% on 15 liters NRBM. IV access was taken and the fluid resuscitation was started. The team was well versed with managing airway, so they intubated this patient with man in line stabilization of the cervical spine, and he was brought to EMS. Here, the patient's vitals got worsened. Heart rate dropped to 100 per minute. BP was 90 by 50. So NORAD was started to keep MAP of more than 80, and he needs high oxygenation ventilatory requirements also on the ventilator. So, can anybody enumerate what are the problems? What was the initial situation, and what is the reason for his hypoxemia and shock in this case?
Hello, ma'am.
Anybody?
Myself, Dr.
Yes.
Pankaj.
Okay.
So, a 30-year-old man came across a road traffic accident, having a uh, having an injury, became unconscious, uh, and
No, can you just tell
his
me the
GCS dropped
important
to
findings in
8.
this case?
Uh, Sorry, ma'am.
Just tell me the concerning points in this case. Young male, that is also an important point. Dangerous mechanism, mode of injury. So because he had a collision with four wheeler, speedy four wheeler. So just tell me highlight the important points. Like young male is there, dangerous mechanism, mode of injury is there, low GCS at from the beginning. It's 8. So just tell me the salient important points in this case. Other important points being
In his poor
hypoxemia.
GCS, ma'am,
Yes. And
hypoxemia
uh,
requirement. Then further he deteriorated, became hypotensive.
yes. So both hypoxemia and
Most probably the
hypotension.
shock, both, ma'am. Most probably the reason of shock would be
Yes. But there might be another reasons until proven otherwise. When in patient, it looks like polytrauma patient coming with hypotension. Probably the reason is hemorrhagic shock, but we need to rule out other shocks also. So you need to utter other things also.
patient can go into cardiogenic shock also due to Takasubo syndrome.
Okay, but tell me the commonest things first, no? Because he's hypoxemic, hypotensive, shock,
Can have
and first
can
you
have
have to
ma'am
rule out.
tamponade, can have cardiac
Yes, very
tamponade
good.
also.
Yes. You have to rule out
Then
It
obstructive
also
shock.
have the
pneumothorax,
neurogenic shock.
pneumothorax, tension
Tension
pneumothorax.
pneumonia.
Yes. So first you should utter obstructive shock like tension pneumothorax, pericardial tamponade, that you need to rule out. If that is ruled out, then hemorrhagic shock is the commonest possibility. Another being because we don't know about the spine, he was unconscious. So it might be neurogenic shock related to spine or neurogenic shock because of the brain also. That we'll see how. But because due to brain, initially he had a hypertensive response, so might be that time because of the severe neurogenic injury, he might later on had a stunned myocardium. So neurogenic stunned myocardium or stress cardiomyopathy, cardiogenic shock, any cardiac injury, because it looks like a polytrauma case. So you need to utter all these shocks. The common one
What
being
about septic shock?
no, I mean this is the first hour of injury, so septic shock might not develop in such a short time period. So you should not utter septic shock, but you can say distributive shock. So even your neurogenic shock is a distributive shock. Or whenever there is a severe SIRS response, then also because of the severe traumatic brain injury, there will be release of lot of catecholamines and cytokines that can cause distributive shock also. But here the commonest being obstructive, hemorrhagic, cardiogenic. You need to utter all these shocks. And reasons for hypoxemia.
Okay, there are quite a
Ma'am,
number of reasons
fracture of
why this
rib,
patient will be hypoxemic. Number one, because
laceration
of
of lung,
the depressed consciousness, he may have
then
airway obstruction. So
Yes,
airway
obstruction,
obstruction
then
is a
aspiration.
possibility. Then it may also be as a result of it may be apparent because of the hypotension. The SpO2 may be low because of hypotension.
Yeah, but
That's
the
it.
commonest being first you have to rule out lung related things. So
Okay.
yes, poor GCS can cause loss of airway and aspiration. Another
Yeah.
thing is commonest being if lungs are like there is a pneumothorax, tension pneumothorax, lung contusions. Because of that also airway injury. So those also these might be the reasons for hypoxemia, and severe shock also can cause hypoxemia. So he got
one
intubated at the
one
site.
more reason, ma'am. After fluid
Yeah, tell me.
resuscitation, patient can land up into fluid.
Yeah, but again, this is the like golden hour. Like first, it's immediately after the initial insult, he was shifted. So all these things will come later on. So what immediately you are suspecting is what I was uttered just now. So you need to intubate such patients with low GCS less than 8, those who are not able to handle their airway or there is an injury to the airway. Uh, uh, when despite patient here, one more important thing is despite patient being on NRBM, saturation is 92%. If uh, the patient is saturating less than 90% after giving supplemental oxygen, even if he is maintaining airway, it's better to intubate if he's not maintaining oxygenation, because secondary brain damage is equally important to save the patient, to avoid this secondary brain damage that you can avoid by maintaining oxygenation as well as maintaining blood pressure. It's very important. So then how will you proceed with this case? Once patient is in ER, intubated, so started on NORAD. Wha- can you tell me what you do in all trauma cases? How you'll start? How will you manage such cases? So you have to utter A, B, C, D. Can you tell me a primary and secondary survey?
I mean, we have to do the primary survey, ma'am, where we look for airway breathing and circulation, and uh, we have already protected the airway and controlled the bleeding, supporting the circulation. Look for any disability. The patient is unconscious, and we have to expose the patient to look for any toxin or any in major injuries to rule out. And then after the stabilization of the patient, once the airway has been protected, the circulation has been established, then we will go for head to toe secondary survey.
Yeah, but you see, for EDIC exams and even for managing patients, you have to be very you need to read the guidelines and you need to be very particular about certain things. Like when you are uttering airway, you have to say cervical spine stabilization, airway with cervical spine stabilization or
Yeah,
cervical spine
ma'am. Yeah,
protective
ma'am.
measures. When you are uttering breathing,
Since
you have to tell whether if the patient has a labored or obstructed breathing because of let's say pneumothorax or tension pneumothorax. So you might need to do decompression thoracotomy. When circulation, you have to utter hemostasis. You have to start with the fluids, but again in polytrauma cases we don't overdo it. In British trauma guidelines, they are trauma guidelines. They have mentioned you resuscitate only with 1 liter of crystalloids, uh, because in polytrauma you accept permissive hypotension till the time of hemostasis. So airway with cervical spine protection, ventilation, SOS, decompression if there is a tension pneumothorax, circulation with hemostasis, disability, and environmental exposure means then taking care of hypothermia and other stuff. So you have to utter these things. It's very important. And again in circulation, when it is associated with the TBI, then permissive hypotension should not be your management, because secondary brain injury, avoiding secondary brain injury is equally important. So already the primary injury has happened. You have to limit the primary injury and you have to avoid the secondary injury. So what are the primary adjuncts, primary survey adjuncts? So just managing ABCD is not like definitely it is important. Along with that, you have to do certain things to immediately come to conclusion. I have already mentioned on my slide.
Okay, let me add something. I'll rather put it this way, that during primary survey, we look directly for potential life-threatening events. Just like you had mentioned, look for signs of airway obstruction and respiratory difficulty as may occur from tension pneumothorax and cardiac tamponade. And then look for bleeding, bleeding into the like hemothorax and
No,
pneumothorax.
you have to utter in A B C D E fashion. You have to do that.
Okay.
So you have to utter primary survey. In primary survey, again primary adjuncts. Primary adjuncts means if you are suspecting tension pneumothorax, you'll quickly ask for X-ray. You'll immediately do bedside EFAS. That is also part of primary survey. It's a primary survey adjunct, because these have it rules out your shocks and helps you manage your case further. So you have to immediately go for EFAS, because patient is hemodynamically unstable, not able, you're not able to shift him to CT room. So better to do bedside EFAS to know whether he is bleeding or whether there is a tamponade, whether there is a tension pneumothorax, or there is a neurogenic pulmonary edema. So in my first slide, when patient had a hypertensive response, when there is a severe traumatic brain injury, there is this catecholamine and sympathetic surge that leads to sudden release of this catecholamines, leads to increase in afterload, and then patient might develop neurogenic pulmonary edema. And that's why in initial part, despite this hypertension, there was no hypotension but hypertension and desaturation. So these all things might occur simultaneously. So EFAST you have to utter. And can you read this ABG? What is the abnormality?
Ma'am, slide is not moving.
No, so this is the ABG and E. Can you read this ABG? ABG, it's, I mean, these two lines are there, no, on the slide. Can you see this ABG?
No, we can't see any
Mom, the
ABG
slide is stuck
results.
in slide 1.
But I am able to move this.